So we're going to continue on here looking at the actual tracks within the spinal cord. So quick review of the anatomy of what we're looking at here. So notice how the spinal cord sits within the vertebral body with the exiting of the peripheral nerve through the between the vertebral arch. Notice where the dorsal root ganglion happens to lie as it relates to the motor nerve exiting. Notice the anterior and posterior orientation. Also look at the meningeal layer and notice how the dura is going to narrow down and collapse on top of the arachnoid and the pia, where it's going to go ahead and form into that epineurium that we saw when we looked at the nerve itself. So within the spinal cord itself, notice how we have the white columns, and notice how we have three distinct patterns of white column. We have the posterior, the anterior, and the lateral. This is the area where we're going to see the tracks traverse through the spinal cord. Now notice within the gray area, this is the area where we're going to see the cell bodies. This is where the interneuron for the sensory pathway will be housed, and this is where the cell body for the lower motor neuron that's going to exit the spinal cord is going to be housed. Notice that we have the central blood vessels within the spinal cord, just as with the cerebral cortex. We're going to have constant rates of perfusion heading through the tissue, making sure that we have the required nutrients as well as the constant exchange of gases so that we can have the aerobic metabolism that needs to take place. So what we're looking at here is we're looking at the actual pathways. So what we end up having three distinct sensory pathways. They're indicated in blue. And then we have two primary motor pathways, and then a few what are referred to as secondary or extrapyramidal motor pathways. All the motor pathways are indicated in red. So we end up having two principal sensory pathways. The posterior column medial lemniscal pathway, which is going to be in the most posterior aspect of it. And then we have the spinal cerebellar, which is primarily going to be in the upper regions of, or the most superior regions of the spinal cord. And then we have the spinal thalamic tract. The spinal thalamic tract and the posterior column medial lemniscal tract are going to be the principal pathways of sensory input from the body, whereas the spinal cerebellar and trigeminal thalamic are going to be primarily responsible for cervical and facial sensory pathways. The motor pathways are going to include the cortical spinal, and there's two principal ones. The anterior, notice where it's at right in front of or right anterior to the commissure, the connection point within the spinal cord, just lateral to the median fissure. And then we have the lateral cortical spinal tract. Notice how it's just posterior and just lateral to the lateral horn. And then we have four principal secondary tracts or extrapyramidal tracts. Those include the rubrospinal, the vestibulospinal, the reticulospinal, and the tectospinal. The cortical spinal is responsible for volitional control of the extremities and the trunk, whereas the extrapyramidal are going to be involved with reflexive and autonomic or automatic responses due to sensory input. So we're first going to look at the sensory pathways. The sensory pathways are made up of distinct sequence of neurons, which we refer to as first, second, and third order. The first order is going to come from the receptor to the spinal cord. The second order is going to head to the thalamus. This is the neuron that's going to cross decussate to the opposite side. So remember, right hemisphere is going to be responsible for left, and left hemisphere is going to be responsible for right. in terms of somatic sensation. So my left primary somatosensory cortex is going to be picking up information from the right side of my body, whereas the right hemisphere of the primary somatosensory cortex is going to be picking up stuff from the left side of my body. We have three principal tracks that we're going to be looking at. We're going to be looking at the posterior column medial lemniscal tract. Now, please, you don't have to try to remember how to spell this. PCML. And then we have the anterior lateral or the spinal thalamic pathway. And the last one that we're going to look at is the trigeminothalamic. So let's take a look at each one of these pathways in terms of what they're going to convey and where we're going to find them. So the first pathway we're going to look at is the PCML. The PCML is going to convey senses of touch, pressure, vibration, proprioception. It's going to come from the limbs, from the trunk, from the cervical region, from the neck, from the posterior part of the head, and it's going to bring things through the thalamus and into the primary somatosensory cortex, the correct primary somatosensory cortex. So if it's on the right side, such as on the image, it's going to convey information to the left. If it's on the left side, it's going to convey information to the right. So if we look at the lowest image where we have receptor to touch, pressure, vibration from the lower limbs and trunk, it's going to head into the dorsal ganglion. That dorsal ganglion will then convey the information along to an interneuron where it's then going to ascend through the posterior column within the fasciculate pathway, the most medial of the fasciculate pathway to be specific, at which point in time it's then going to hit into the caudate region of the medulla oblongata, where it's going to head into the lemniscal region of the pons. It's at that region that we get our second order neuron. That's where we get the synapse. And what's going to happen is it's going to go ahead and it's going to cross. It's going to decussate at that level. It's going to cross, proceed through the thalamus, where it's going to go ahead and synapse onto one of the red nuclear regions, the ventral posterior region. And then it's going to head out through the third order neuron into the primary somatosensory cortex. Now notice on the other side, where we're getting something from the upper trunk, from the neck, from the posterior part of the head, it's going to come in, and instead of going into the medial fasciculate tract, it's going to pass along through the lateral fasciculate tract. This is then going to, within the nuclei of the medulla, it's going to synapse and it's going to decussate. It will then pass through the medial and meniscal region of the pons and then head into the thalamus, where once again it's going to synapse within the ventral posterior part and then head out into the primary somatosensory cortex. Now within the thalamus, what you want to do is go ahead and head back into the packet and look at the diagram as well as the various nuclei and regions within the thalamus to review those areas so that you are aware of what each one is going to be doing. The next pathway is the anterior lateral otospinal thalamic pathway. This is going to control things like pain, temperature, cold and warmth, itch, tickle, from the limbs, neck, trunk, posterior part of the head, and it's going to convey them up to the cerebral cortex. Now this pathway is a different pathway than what we just saw with the PCML. It's involved with the need to remove a stimulus. The difference between pain, itch, and tickle is level of stimulus, consistency of stimulus, and whether or not tissue is being destroyed. What ends up happening is that we're going to get passage into the dorsal horn, at which point in time we're going to immediately synapse onto the interneuron. This will then traverse as a decussated pathway onto the opposite side. It will also send motor signals to the anterior and into the lateral horns, or into the ventral and lateral horns of the spinal cord, to instigate a automatic response, a reflex behavior. The ascending pathway will head into the olivary region within the midbrain, within the medulla and the pons, the hindbrain, within the medulla and the pons, which one time is then going to pass through the thalamic region. As it passes through the thalamic region, we're going to get our third order neuron coming into play, which one time is then going to convey the information onto the primary somatosensory cortex. Sometimes this pathway instigates the automatic reflex response, such as what we see when we use the reflex hammer to test reflexes. This is the same pathway that's going to become involved when you touch something that's hot or when you touch something that's sharp. The last pathway we look at is the trigeminal thalamic. Trigeminal thalamic is responsible for sensation to the face, the nasal opening, the oral opening, and in through the jaw. So here we're looking at the trigeminal thalamic pathway. In the trigeminal thalamic pathway, what we're looking at is we're looking at receptors coming in along one of the three branches of the trigeminal nerve, either the ophthalmic up by where the eye happens to be and into the frontal bone, the maxillary within the zygomatic region and across through the nasal region, and then the mandibular region down along the mandible. This is going to go ahead and it's going to convey information both at that level and below that level. So what it's going to do is it's going to send information down one level into the medulla as well as straight across through the pontine nuclei. And then it's going to go ahead and ascend into the thalamic region, at which point in time it's going to synapse on multiple neurons and then pass out into the primary somatosensory cortex. Now, what you're going to notice with the trigeminal thalamic as well as with the cortical bulbar pathways is that we get both contralateral and ipsilateral information happening at the same time. What this does is this ensures that we get a binocular sense across the face as well as a bilateral control of facial motion, something that is different than what we see with the other pathways. So that takes care of the sensory pathways. So let's take a look at the somatic pathways. The somatic pathways are going to start with the upper motor neuron coming from the pyramidal regions. They're then going to synapse in the ventral horn and in the lateral horn onto the lower motor neurons, which will then exit and take the signal for muscle function. It involves neural circuitry within the thalamus and within the limbic system from the basal ganglia and the substantia nigra, as well as the cerebellum, in order to regulate activity of the upper motor neurons so that we have proper function. This is where we have to worry about Parkinson's and Parkinsonian issues that disrupt motor function. I'll talk a little bit more about this when we talk about function in terms of pattern of motion in the peripheral nervous system. But it's these issues that people who have dopamine issues have Parkinson's, where they have issues with motor initiation. They don't necessarily have the shaking and tremoring that we usually associate with people with Parkinson's. That is more of a side effect of the medication. So let's take a look at the cortical spinal pathways. There are two distinct tracks of the cortical spinal pathway. We have the anterior track. The anterior track is going to control the proximal region of the limbs. It's going to pass through the cerebellar peduncles out to the cerebellum in the back, passing along through the pons into the pyramids, where we're then going to pass down through the anterior region of the spinal cord, through the anterior cortical spinal tract. We are then going to decussate, cross into the opposite side, into the ventral horn, where we're going to exit out. Now, this pathway is going to control anything that is around the pectoral girdle heading down into the upper extremity, or around the pelvic girdle heading down into the lower extremity. So this is the pathway that's going to control things like the deltoid, the biceps brachii, triceps brachii, the rotator cuff muscles, the pectoralis, the gluteus muscles, the muscles that are going to flex and extend the hip. It's also going to take care of controlling anything that's going to regulate the trunk. So this is the pathway that's going to help me keep an erect posture. This is the pathway that's going to become involved if I have to do any type of rotation or movement around to ensure that I'm not spinning too fast or too slow. The next pathway is the pathway we're looking at here, which is the lateral cortical spinal tract. The lateral cortical spinal tract is going to head through the same pathway we just saw with the anterior pathway, except at the pyramids, it's going to go ahead and decussate. It's going to cross within the pyramids of the hindbrain. It's then going to descend through the lateral cortical spinal tract. It will then synapse within the lateral horn and the ventral horn, depending upon where within the pathway we're going to head out. Is then going to head out and it's going to control anything that is distal to the first few centimeters of the extremities. So anything that is basically inferior to the insertion of the deltoid, or anything that's inferior to the insertion of the gluteal muscles in the upper extremities for the deltoids and the lower extremities for the gluteal muscles, are going to be controlled by the lateral cortical spinal tract. Now, this lateral cortical spinal tract is the tract that is going to be involved with control and dexterity movements, movement of fine motor control of the hands and the foot. This is also the tract that gets impacted through impacting on the lateral horn when someone has a disease known as Lou Gehrig's disease, or what is medically referred to as amyotrophic lateral sclerosis, or ALS, as we start developing amyloid plaques within the lateral horn of the spinal cord. The last of the primary tracts is the corticobulbar tract. The corticobulbar tract is going to allow us to control facial functions as well as motor functions of the head and neck, particularly motor function as relates to swallowing, speaking, and movement of facial muscles. It's this movement of facial muscles that allow us to do things like smile, look shocked, etc. Now, what this pathway is, just like we talked about with the trigeminal thalamic pathway, is that we have both contralateral and ipsilateral control coming out of this. So what's happening is we have a motor signal that's going to pass through the cerebellar peduncles to ensure that we have the correct motor pathway, and it's going to then synapse onto the facial nerve. Now notice it's going to synapse both ipsilaterally as well as contralaterally onto the facial nerve. What this ensures is that we have symmetrical motion of facial muscles so that the motor coordination is correct to allow for proper expression as well as proper speech pattern. The facial nerve is what gets impacted when we have things like Bell's palsy, where we have paralysis of that facial nerve due to demyelination. And what's happening is that we'll send a signal that says smile, and the affected side will end up not being able to smile. We have a flat affect, or we'll say blink, and we will be unable to blink, or we'll send a signal that says time to close the eyes, and we won't be able to close the eyes. The palatal muscles will not allow for the actual eyelids to close. So those are the principal motor tracts. The other tracts we look at are referred to as the extrapyramidal or the indirect tract. These are going to be involved with responses to special senses, responses to stimuli that we need for instantaneous response, or response to movement in space. We have to be able to keep an erect posture or to control spin rate. So things like the rubrospinal tract coming from the red nucleus of the thalamus, Things like the tectospinal tract coming from the tectal plate and the genicules and collicules that relate to the ability to have eye tracking in response to things flying in the environment. The vestibulospinal tract, the ability to have and keep truncal support. And then the reticulospinal tract, which is going to be involved with fine motor coordination as relates to sensory input and feedback. We'll get more into this when we look at the special senses.